ઇન્સ્પિરેશન જોઈએ છે તમારા બધાથી.
I agree with you.
Yeah,
Bhavi is right.
it's very
Good evening,
So
sir.
whatever small impact we can do is good, and there is always a small impact.
Exactly.
Good evening, sir.
ગુડ ઇવનિંગ.
ગુડ ઇવનિંગ. ગુડ ઇવનિંગ દિવ્યાંગભાઈ.
હા દિવ્યાંગભાઈ, ગુડ ઇવનિંગ.
બરાબર.
તમારા આર્ટિકલ તો અમે ગુજરાત મિત્રમાં બહુ વાંચતા હતા ત્યારે યુજી હતા ત્યારે.
જો એટલે આ તો તમને
લાઈવ એક્ઝામ્પલ આવી ગયો.
મળ્યા.
અમે વાઇવામાં પછી એમાંથી જવાબ આપતા.
લો ચલો, જો પાસ થયો દિવ્યાંગ એના ઉપર તો સાહેબ તમારે ફરક પડ્યો, જો જોઈ લો.
P4P માટે પણ બહુ કર્યું નહીં કેતનભાઈ તમે તો?
હા, હજુ બી ઘણું કરીએ છે.
રાઈટ.
ઘણું કર્યું.
Ketan sir was the first who inspired for breast meat donation camp project Yashoda. યશોદા જે ચાલુ થયું એમાં સર પહેલી વખત મને યાદ છે કે I was a R3 at that time.
Oh wow. So I mean long back.
અરે બ્રેસ્ટ ફીડિંગ પર તો લોંગ બેક 1991 માં તો બુક લખી પહેલી. ન્યૂઝપેપરમાં કોલમ લખેલી આખી ને પછી બુક બનાવી.
રાઈટ. એ બુક આઈ ગેસ ઇન્ટરનેટ પર છે તમારી, નહીં? બેબીની ફીડિંગની ને બધા જ એના સાથેની સારી છે એ બુક, બહુ સરસ છે, વેરી યુઝફુલ. યા એગ્રીડ, વેરી બ્યુટીફુલ. વચ્ચે મારે આમ જ કંઈક બીજા કામથી સર્ચ કરતી હતી અને મળીને આઈ હેવ ડાઉનલોડેડ, વાંચું છું. સરસ.
તમારે છે ને ચાઇલ્ડ સેક્સ્યુઅલ એબ્યુઝ ઉપર આખું મેન્યુઅલ પણ બહુ સરસ છે.
અચ્છા, શેર કરશો?
લર્નિંગ ડિસેબિલિટીઝ પર આખું બહુ મોટું મેન્યુઅલ છે. એ બી બહુ
રાઈટ. ના એ કરજો ને તો શેર અનુકૂળ પડે તમને.
સુસાઇડ પ્રિવેન્શન ચિલ્ડ્રનમાં એના પર બી ઘણું સરસ છે.
રાઈટ.
બધા મેન્યુઅલ્સ છે તે પોલીસ અને ડીઓ ડિસ્ટ્રિક્ટ એજ્યુકેશન ઓફિસરો અને બધા
એ આઈ થિંક અમુક છે. બહુ વખત પહેલા જયારે P4P માટે આપણે અહીંયા પણ પ્રોગ્રામ કર્યો હતો ને ત્યારે હા જોયું હતું.
એટલે મેન્યુઅલો આ પોલીસ ને બધા વાપરે જ છે સુધી.
વેરી નાઇસ. 2-1 મિનિટમાં આપણે સ્ટાર્ટ કરીએ.
1 મિનિટમાં ભાભી મેડમ.
હા, 1 to 2 minutes.
ભૂપેન્દ્રભાઈ સ્ક્રીન શેર કરી જોઉં?
હા કરી જો સાહેબ, નો ઇશ્યુ.
હા એકવાર કરી લો ને. યસ.
હમણાં તો છે ને ખારેલમાં એક સરસ પ્રોજેક્ટ લીધો છે, રિસ્પોન્સિવ એન્ડ પેરેન્ટિંગ નર્ચરિંગ કેર પર.
રાઈટ.
3 વર્ષ થઈ ગયા.
પોસ્ટ બનાવવું પડશે તમારે મને.
હા હું બનાવી દઉં.
હા પછી થશે.
નહીં જરૂર પડે.
મીટિંગમાં છે. હા હમણાં એમ જ થઈ ગયું હતું.
નહીં જરૂર પડે દિવ્યા.
કઈ બાજુ છે શેર? હા શેરમાં આવે છે ત્યાંથી.
યસ
શેરમાં.
સ્ક્રીન
લાવ ને મોકલ.
એન્ટાયર સ્ક્રીન
about to join. Okay.
આવે છે ખરું?
આ બધું શું કામ બતાવો છો?
તારો સ્ક્રીન આવે છે અને
હા બસ આવી ગયું.
પીપીટી ઓન કર.
આવી જશે.
એ જ કરું છું.
Welcome Kashi sir. Welcome Kashi.
Is it visible?
Yes, screen is visible. And Dr. Kashi sir has also joined us.
Yes, joined us.
Great.
Good evening, everyone.
ગુડ
Good
ઇવનિંગ
evening,
સર.
sir.
ગુડ ઇવનિંગ.
Good evening.
સર ગુડ મોર્નિંગ.
સર માટે ગુડ મોર્નિંગ. યસ.
So what time it is there now?
Now it's
9 o'clock,
8:30 a.m.
Achha, 8:30.
Bhavin, you can start now. Dr. Bhavin,
Yes, sir.
Good morning, sir.
you can start now.
Welcome, sir. Welcome, sir. Welcome, everyone. Good evening and warm welcome again. I am Dr. Bhavi Shah. It gives me immense pleasure to welcome you all today for the 4th CRISP webinar, a topic on adolescent immunization. that is increasingly important in preventive healthcare and public health practice. Adolescence is a unique transitional phase marked not only by rapid physical and psychological growth, but also by changing health risk and opportunities for preventive care. As we all know, the childhood immunization has received immense attention all over the years, while adolescent vaccination often remains under-recognized, despite its crucial role in preventing serious infectious diseases and ensuring long-term health, preventive, and protection. So, as healthcare professionals, caregivers, and educators, it has become our collective role to bridge this gap, okay, in awareness and in practice. So, today's webinar is all about it. It is aimed to highlight latest recommendations, challenges, opportunities, and practical approach in clinical practice. So again, I extend a warm welcome to all our esteemed speakers, panelists, respected faculty members, and every participants who has joined us. It itself reflects your commitment toward advancing adolescent health and strengthening of the preventive medicine. So we are honored to have distinguished experts, Kasi sir and Kulkarni sir, and all the distinguished panelists amongst us for sharing their valuable knowledge, experience, and insight on such important subject. I am confident that today's session will be highly interactive, informative, and beneficial to all the attendees.
You have a
I
wild.
Okay, sorry. Okay, I would also like to express my sincere gratitude towards the organizing committee GAHA and everyone who is working behind the scenes for making such webinars possible. So without further delay, let us begin academic session with enthusiasm and spirit of learning. Thank you all once again, and I wish everyone a very enriching webinar ahead. I welcome Dr. Bhupendra Kapadia, sir, our Honorable Secretary of GAHA, for welcoming session further. Over to you, sir.
Thank you. On behalf of Gujarat Adolescent Health Academy family, I welcome you all for today's episode 4 of Gujarat Adolescent Health Academy CRISP webinar series, that is case-based discussion on adolescent immunization strategies. So I welcome all the delegates as well as today's moderator, panelist, and expert guest for accepting the invitation at the very first moment itself. So now I invite our Gujarat Adolescent Health Academy chairperson, Dr. Snehal Sirolawala, for her welcome speech. Dr. Snehal, madam.
Thank you, Dr. Bhupendra. Good evening, one and all. It's indeed my pleasure to welcome you all as we conduct the 4th episode. I am so happy that each month we come forward with unique webinar series, and I thank all my EBs, Secretary Bhupendra and Dr. Samir Shah as scientific chairperson for bringing out innovative ideas and expert speakers for the panel. Today's topic is case-based adolescent immunization strategies. And for that, we have dynamic moderator, Dr. Divyang Patel, and we have excellent panelists like Dr. Umesh Bhai, Dr. Tushar Bhai, Dr. Ketan Bhai, and Dr. Yagnesh sir. My sincere thanks to all the panelists and moderator. And it would be less if I don't express my thanks and sincerest gratitude to Dr. Kashi sir, who has agreed and joined from USA. Thank you so much, sir. And Dr. Ganesh Kulkarni for their kind acceptance to be an expert guest for today's session. I'm sure with such eminent speakers, we'll have an excellent session today. And let us enjoy the session. Thank you so much. And over to you again, Dr. Bhavi.
Thank you all. Now, let me take the opportunity to invite all the esteemed. Yes. So all the esteemed guests for today's panel discussion, as well as my chairperson, Dr. Snehal Sirolawala, project in charge, Dr. Samir Shah Sahib, and all the panelists, as well as moderator, and all the attendees. And now I request our project in charge, Dr. Samir Shah Sahib, to release the menstrual hygiene day video, which we have made over a period of days to deliver the best message on this menstrual hygiene day, that is tomorrow, 28th May. Dr. Samir Shah, sir.
Hello, dear teens. Growing up comes with many changes, and getting your period is a natural, healthy part of becoming a woman. It's not something to be ashamed of or kept as a dark secret. It's a sign of health.
Menstruation is a periodic discharge of blood and mucus from the inner lining of uterus through vagina. As it happens regularly at a regular interval, it is also known as periods.
Average cycle lengths of 28 days and duration of 5 days. The 28th of May every year rated as World Menstrual Hygiene Day.
A girl loses usually 30 to 40 ml of blood per menstrual cycle. It means she uses less than 16 pads per cycle or less than 5 pads a day. There are usually no large clots seen.
You can choose many kinds of menstrual products to absorb or to collect blood during periods, including sanitary pads, tampons, menstrual cups, menstrual discs, and period underwear.
Keep a period kit in your bag with 1 to 2 pads, a small Ziploc bag, a spare underwear, a wipes pack, and a pain relief roll-on if needed.
Change sanitary pads or tampons every 6 to 8 hours to stay fresh and to prevent bacterial growth, no matter how light the flow is. Change them more frequently if your period is heavy.
Never ever flush the pads down the toilet. Always wrap them in the paper and toss them in the bin to keep the things clean. For menstrual cup, follow the sterilization process.
Use a calendar or an app to track your period dates. Irregular periods can be a sign of underlying illnesses. To know when your period is coming helps you to feel in control.
If you have cramps, warm water bottle, light stretching exercise, and keeping yourself works very well.
Always wash your hands with soap and water before and after changing your period products and also after using the restroom.
Wear lightweight, breathable clothes. Shaving of genital hair is not recommended. Trimming can be done.
Wash your external private area with plain water daily. Wipe from front of your body towards the backside. Your body is amazing at cleaning itself internally, so no need for vaginal wash.
Use unscented toilet paper, tampons or pads. Scented hygiene products can irritate the skin and impact your natural pH balance.
Eat iron-rich foods like green leafy vegetables and beetroot because your body loses a little iron during the flow. If needed, your doctor will prescribe iron tablet.
Decrease coffee, sweets and sodium intake. Exercise 60 minutes a day. Maintain normal BMI and have a relaxation time.
You can run, dance, swim and go to school. Your period doesn't have to stop your life.
And to ask, if you feel extreme pain or heavy bleeding with clots or have any doubt, don't hesitate to talk to your doctor or any trusted adult.
Mood swings during periods are normal. Rest when needed, and remember, it's okay to ask for a help. Your emotional health too.
Here we talk about all the aspects of menstruation that are essential, not only to make you feel comfortable, but also to prevent infection and complications if any. Just remember, no fear, no shame, just care every time everywhere. Thank you.
This was very informative and such an insightful video on the menstrual hygiene. I'm sure every female is going to get aware. I hope it gets spread across the state and central areas of India, which is very much needed nowadays. So, moving forward, I would like to invite Dr. Shamir Shah sir for giving overview of the today's webinar topic. Over to you, Samir sir.
I think there is no much to say because already you had given enough introduction of the topic. So let's start with our main agenda. Thank you.
Okay, sir. Okay. So moving forward, I think we'll go for the introduction of our faculty members. Just give a 2 seconds. Okay. Okay. Oh. So I don't think Srinivas Kasi sir requires any introduction. Am I audible?
Yes, ma'am.
Okay. So it is an absolute honor and a privilege to have Dr. Kashi sir as our expert today. He is consultant pediatrician from Bangalore, past president IIP Bangalore, past vice president IIP National Respiratory Chapter. He has been member, convener, advisor over the decades and editor of the very important IAP question and answer in vaccinology and IAP Purple Book. He has contributed chapters on vaccinology and various IAP textbooks and delivered more than 10 orations and 2 endowment lectures. Welcome, sir. Again, we have Dr. Ganesh Kulkarni, sir, a very esteemed pediatrician who is direct.
Brilliant, Pauline. Once again.
Sorry.
Request everyone to please keep muted.
Yeah, please keep the mic mute. Okay. So moving forward, we have very esteemed Dr. Ganesh Kulkarni, sir, Director and Chief Pediatric Consultant, Sanjeevani Children's Hospital, Aurangabad. He has been a national elected CIAP Executive Board member for 1819. He has been a Vice President of Maharashtra State in 2017 and past national convener IIP DG Academy 20 and current for the year 2026 for DG Academy. He has areas of expertise in infectious diseases, vaccinology and nutrition, and paper publication again on simplified vaccinology and clinical trials and vaccines. So that's quite a vast area in vaccine he has covered over the years. And a dynamic moderator, Dr. Divyang Patel sir, who has been a guiding force for me. And he's again an MD pediatric working in Vardhan Hospital, Modasa. He is EB member currently of CIAP and over the years he has been EB of AOP Gujarat. Also, he is currently EB AHA Gujarat 2026 and again president of IMM Modasa and AOP Sabarkantha branch. And he has trained multiple training programs and has trained multiple students under him. Again, a distinguished Dr. Unmesh Upadhyay sir. He's our panelist today, Director Consultant Pediatrician at Vismay Child Care Hospital, President of Pediatric Association Ahmedabad for the year 23-24, ADVAC Fellow, Geneva 24, and writer of IAP TB of Vaccines 2020 and FAQ on vaccines and immunization and adult immunization in office practice 22. He is currently a IAP ACVIAP member. Dr. Tushar Shah sir, a very esteemed pediatrician from Baroda. He was a president Academy of Pediatric Gujarat 24, Director MVAC Healthcare Solution, Director Department of Clinical Research, and consultant ex-professor KGP Children Hospital, Baroda. He has been chief consultant proprietor of Navkar Children Hospital and editor of adult immunization in office practice, JP Brothers, 23 and for the year 26. Again, a renowned personality, Dr. Ketan Bharadwaj sir, who has been a source of inspiration for all of us. He has been a chairperson for Infant Young Child Feeding Chapter of Indian Academy of Pediatric 19 and 21, Human Milk Banking Association, a trajectory many would not have touched in their entire life, and a coordinator of scientific IAP JJ project, breastfeeding and human milk bank promotion SPECT, project Read and SPECT, and he has multiple awards on his name: Limca Book of Records for breast milk donation camp, WABA Gold Medal 2008 on his name, Fellow of Indian Academy of Pediatrics, and IAP Unique Community Services 2019. These are all the awards he has received. Congratulations, sir. And author of various publications based on IACF, human milk banking, micronutrients, and learning disability screening test, and various books for feeding and learning and mental health of children. So sir is also visiting faculty of PG diplomas in dietetics, learning disability, counseling, and physiotherapy, the need of the today's world. Again, Dr. Yagnesh Popat, sir, a very renowned personality, is a director, Om Baby Care Hospital, Rajkot. He has been a vice president for IMA Headquarter 26 and a chairperson IAP ID Chapter 21, EB Central IAP, and presidential AOP Gujarat, president of AOP Gujarat 2006. He has special achievements and he has been editor of Coffee Table Book on Vaccine and Vaccinology, Coffee Sip Publication, IAP Presidential Program 2025. And also he has published various books like IAP ID textbook, Protocol on Common Pediatric Disorder articles in IP and IJPP. He is organizer of many national and state level events, as we all very well versed from. So thank you everyone on board. It has been an excellent expert and panel here today for the session. So I would like to hand over the further session to our dynamic moderator. Without further delay, Dr. Divyang Patel, sir. Let's begin the interactive and informative session.
Before starting the session, welcome Dr. Sushma Madam and Bhupendra sir.
So herewith I take this opportunity to welcome our Central AHA Chairperson, Dr. Sushma Desai Madam, for our today's webinar, episode 4 of this webinar series. Welcome, Madam.
Thank you, Bhupendra Bhai. I will not take much time because I am late, which I am never. I was with another meeting and that was also an inaugural. It is so very pleasant to see my home team on the virtual platform coming up with so much innovative work and with the excellent faculties today, Dr. Unmesh Bhai, Dr. Tushar Bhai, Yagnesh, and the icing on the cake is Dr. Kashi sir, Dr. Ganesh ji. I have seen them working for adolescent, vaccination module, and our very own Dr. Ketan Bharadwa. I wish my bestest of the wishes for the most successful webinar today. And let us start with the webinar and the scientific deliberations. Thank you so much. Thank you for having me here.
Thank you so much.
Thank you, ma'am, for joining us.
Dr. Divyang sir, please go ahead.
My screen visible?
Yes.
Okay. So thank you, our MOC, Dr. Bhavi, and team GAHA for providing a platform to me. It's really topic which is near to our heart. Adolescent immunization, nothing is new. Before 5 to 7 years, if we consider, then there is something new for every one of us that we didn't know about adolescent immunization, or we know very less. But today, day by day, we know very well. So it's just like we know everything, but we practice very little. Why we practice little? That is a question. Just like that, ki janami dharmam nachme pravrutti. We are doing, we know everything, but we are not practicing because of some hurdles are there, some problems are there, and we know that today's need that in India, routine immunization given to young children is decimally low, and there is a tremendous heterogeneity in state to state and district level immunization coverage in India. If we look at Pondicherry, it's more than 95%. If we look at Meghalaya and Nagaland, it's less than 40%. So state to state variation, rural versus urban variation, urban slum versus urban variation, educated versus uneducated variation. So many children reach the adolescent period with no or partial immunization. And universally, the uptake of vaccines in adolescent is inadequate. So every one of us, many of us are aware about this, and we want to give a vaccines, we want to vaccinate, we want to increase the coverage. But what is lacking? We start reading some books, we start reading some journals also. And when we start looking at journals and books, we found such a diagram which are written in Pandulipi that will confuse us. There are so many recommendations, so many guidelines, so many things, and so many heavy words like seroprevalence, GMT, then efficacy, uh, confidential interval. So everyone high recommendation, less recommendation. These all things confuse us as a practical pediatrician. So here I am as a moderator. I have very moderate knowledge. All panelists and experts having excellent knowledge. But I am with a moderate knowledge, and I am here just a representative of everyone who are present as a simple pediatricians who are doing a private practice and who want to give a vaccination to their adolescent, because adolescent vaccination is a need of nation as well of need of pediatricians also, because day by day infectious disease practice is decreasing, and we want to open a new horizon for the practice, and for that pediatric adolescent vaccination is a new horizon. So I have made a case-based presentation here, very practical scenario, and I am very much thankful. Every case was taken from a practicing pediatrician of Gujarat as well as from the India, my friends who have sent me the cases, and all my expert panelists who have supported me a lot in finding out as well as modifying the case, as well as Ganesh Kulkarni sir, who has from very first day he sent the presentation and questions, as well as Dr. Kasi sir, who in his busy schedule he have sent
हाँ
the
कहते हैं बहुत टेस्टी बनती है। अच्छा चक्की ये
I
है
am
वैसी, इसके कोफ्ते भी बन
Dr.
Kindly unmute the mic as it is little
So
disturbed.
Dr. Kasi sir has gone through every all the presentation as he has guided me very well. So I'm very much thankful to all the expert as well as panelists for guiding me. And without wasting much time, we will start with a first case scenario of this presentation. A young adolescent aged 13 years is brought to your OPD for a minor upper respiratory tract infection. Adolescent has not received any vaccine after DPT or OPV booster at the 5 years of age. In the past 2 years, adolescent has visited different pediatricians at least 5 times for minor elements. I request everyone to please mute their.
Chandrabhai, please mute.
So
Divyang.
adolescent has.
Divyang is also mute.
Now am I audible?
Yeah.
So in past 2 years, he has visited different pediatricians 5 times for minor ailments. Can you discuss the reason why this adolescent has not received the schedule? This is not a new scenario. I am not here want to discuss on schedule. I am just want to have a reasons why we not counsel the adolescent for vaccination. So for this question, I would like to ask first Dr. Yagnesh Popat, sir. Sir, give me 2 to 3 reasons why this adolescent perhaps not got this this vaccination despite of visiting a pediatrician.
Thank you, Dr. Divyang, for an inaugural question of this session. Here, there could be a multiple scenarios because the scenarios, the child has visited the multiple pediatricians. Probably the pediatrician would have not inquired about the vaccination status of the child, may not be so much motivated to go for vaccination, could be the one scenario. Probably must have inquired, but the relatives, parents would not have brought that card, vaccination card with them, and they do not know the status. That is why the further vaccination is not advised.
Okay.
The scenario
sir.
could be they had been advised, but they have not followed up. So this could be any situation out of this. Probably
Tushar, sir.
vaccination is the most neglected area where everybody thinks vaccination is for younger children. Once the child grows over 5 years or 7 years, no further vaccination is required. In Gujarati, if we say ask them, they will say, "Badi જ vaccine અપાઈ ગઈ છે." That is what will be the answer will be given by this parents. So we must inquire in detail what is the status and check the record. That is most important. Verbally, answer has no value, frankly speaking. So check the record and list out the vaccine once it has been done. Yeah.
Sure, sir.
Yeah.
I will ask this question to everyone in a
Sure,
different way.
sure.
Tushar, sir,
So here,
any
as has been mentioned,
other reasons for this, because why we miss the vaccination of adolescents?
Right. So here
Any
has been
hesitancy?
mentioned that there was a minor URI. So many a times all these trivial diseases or trivial illnesses also become one of the reason why at times the healthcare professionals also want to avoid vaccinating at that point of time. So we must understand that minor URI, minor diarrhea, some mild symptoms which are not significant, we should not miss the opportunity to vaccinate that child at that point of time. Another reasons beyond this, usually what I see is that the people underestimate the risk of vaccine preventable diseases and they think it is not required. They also underestimate the importance of vaccines for this VPD. So they don't agree to the fact that these vaccines are safe, effective, and are going to help them in a big way. And for a common man, it may be okay, but many times we have seen that even healthcare professionals, like all elite healthcare professionals, are on the webinar right now. But there are many who don't attend such webinars and are not aware or are not very sure about the prevalence of such disease and about the need for vaccination. That also becomes at times a barrier. Another most important thing is that up to 5 years, many vaccines are covered in the national immunization program, whereas vaccines beyond 5, usually they need to make out of pocket expense. So a cost also becomes a big problem when it comes to taking the vaccines. And of course, adolescents have a huge fear of pricks, and they are afraid of multiple pricks, in fact. So when it comes to catch-up immunization, doing more than one vaccines on a given day, it is very easy when we want to do it in a smaller child, but when it comes to adolescent or an adult, it becomes a big challenge. So I think these are another reasons beyond or above what Dr. Yagnesh Bhai has said.
Okay, so we come across the almost all the reasons. I would like to ask Unmesh Bhai. Unmesh Bhai, you are the member of ACVIB. So do you think that is there somewhat lacking in our policy making regarding the vaccination? Do you think that there should be something should be required? Very brief about this, Dr. Unmesh, sir.
Unmute.
I don't think there is a lacking in policy about this against this
question, but I think that in busy schedule, sometimes pediatrician concentrate only on present illness. They do not ask about vaccination, and I think that there should be a vaccine information statement should be kept in OPD by every pediatrician. So in busy OPD, they also counseling in short time about benefit versus risk about every vaccines, and they can train staff, OPD staff also to counseling and check about every patient's vaccination record and advise according to them about catch-up vaccination.
Thank you, Urmesh bhai. Actually, you have also asked my next question also. That is for Ketan sir also. Ketan sir, can you enumerate the opportunities in our busy OPD which we missed it for this adolescent vaccination? Like when should we have to counsel, or which are the opportunities for counseling the adolescent for vaccination?
Yeah, before that, I would like to add 2 more points. First and foremost thing is our careless attitude. Most of us, we don't inquire. If we are going to inquire in each and every child, if our nursing staff at the reception notes down all the vaccine history and all, then we can increase that coverage. But more than that, there is no government program for special adolescent vaccination. So if there is a government program, it reaches to each and every child, each and every household, and they can then know that this is going on, except for certain mass TD vaccination going on in school in some pockets. So that is also very much needed. One more thing is internet. Careless attitudes or anti-vaxxers attitudes, they are being built up. See what is happening with HPV vaccine. So that is also one of the reasons that once when we ask parents to get HPV vaccine, they may be reluctant. They ask us questions. So they have their own doubts. And so these are the main other reasons. But this always can be held by inquiring about history, vaccination history in all the adolescents. School programs, they can be very good to boost the awareness. And we all attend to the college going students in one or the other way in our social projects, and everywhere we go to schools, we can always increase the awareness by making more and more programs about it.
Okay. Thank you, sir. I would like to have an opinion from my expert, Dr. Ganesh sir and Dr. Kashi sir, whoever wants to take up this question. That please enumerate, Ganesh sir, you are also a clinician, very busy clinician, I know. So when you got a time in your OPD for a counseling, which are the opportunities you got?
Right. Oh, it is always an easier job, when you are alongside Dr. Kashi sir, and that makes you so comfortable that somebody is there to back you for whatever things that you commit in a right way or a wrong way. He is going to be there for us. Now there are 2 aspects that we were discussing about. One is adolescent vaccination. Why these adolescents was not given a vaccine after 5 years of age. My concept was, the life course vaccination, this new concept is being established right now. Means vaccination is not only needed for infancy, pediatric age group, young adults, geriatric populations, but over years it has been established that vaccination is only for infancy and pediatric age group. Beyond that, the role of vaccination, neither the parents acknowledge, neither even the clinicians have had any time importance about it. That is the reason perhaps after the 5 years booster is over, hardly a clinician thinks that this particular adolescent needs a vaccine. Now, reason here is because the disease prevalence is very high during infancy and early childhood. These adolescents become very healthy. They hardly go back to the hospital for some trivial issues, because that's a very healthy population. And that is the reason, like, we think that they don't need a vaccine because they don't have any disease. And that's where we probably are lacking. Now, that's one thing, that why this adolescent was not given a vaccine. Now, second thing is, what are those opportunities that, that come to you to give vaccines to these adolescents? Now, coming to that, as I said, they hardly felt, they're not sick any time in their life, these adolescents. And that is the reason why the opportunity for a clinician to interact with them, counsel with them for the need of vaccination does not come. Then what are the opportunities? So probably, one has to have some invitational programs like school vaccination, mass vaccination programs. That's one thing. Second thing is, nowadays we are working on a lot of softwares. These are the babies who used to come to you. They become adolescents sometimes in later. So you have a database of them. So why not to send them messages that now this particular adolescent specific vaccines are due for your age and this is your day. So that's one thing. And the other opportunities, like if at all, whenever they come to you for some other reason, like adolescent related health issues, when they come to you, it is an opportunity for you to counsel them that these vaccines are needed for you. And that's where we can. But there are hardly few opportunities, believe me, that an adolescent comes back to clinician and we get an opportunity to counsel.
Thank you, sir. Dr. Kasi, sir, any?
Thank you. This is probably the most important slide in today's panel discussion. Unless you thrash this out, there's no use in talking about other vaccines. So missed opportunities for immunization or failure to vaccinate a vaccine eligible individual who approaches the healthcare system not vaccinated in spite of not having any contraindications or vaccination is called missed opportunities, or MOI. And this is probably the commonest cause for the low vaccine rates in adolescents. 5 times this child has approached healthcare professionals, pediatricians whose job is to vaccinate, and no one has spoken about vaccines. So the first message is that whatever the reason an adolescent comes to you or any child comes to you, inquiry about the vaccination status is mandatory and it should be recorded if it is incomplete. The second thing we must remember is adolescents, 10, 8, 9, 10 standards, schools are very important. They will take an off because they are ill, but they will not take an off to come and take a vaccine, which they perceive as not urgent. So solution is, when they come with minor illness, vaccinate, or have vaccination hours at a time which is convenient for adolescents to attend. Not part of the general OPD, maybe separate slots so they don't have to take appointments, or wait for long periods in your consultation rooms. I mean, these are some ways in which we can increase the vaccine uptake in adolescents. Thank you.
Thank you, sir. So for pediatricians, those are who are seems to be busy, so you can utilize OPD waiting time, checking height and weight. Your nurses can also counsel. When the adolescent came for sports and fitness certificate with acute minor illness, sometimes we feel that why you came, there is nothing, medicine is required. At the end of consultation also, we can say, after vaccination, we have observation period. In that also, we can we have an opportunity to counsel. It's 30-60 seconds. And along with companion visit, sometimes they came along with their siblings. So that is also an opportunity. And perhaps all of us are convinced with this. So with this much of thought, we are ready to grab the opportunities every time. So now we have one patient which came, a 30 years old boy came for a fitness and vaccination certificate, as he is due to go on trekking for 2 weeks after 8 to 10 days. He has received all vaccines up to 5 years at government CSC as per the National Immunization Program. So, Dr. Tushar Bhai, how will you counsel and schedule the remaining due vaccines as per IAP schedule in this particularly 13 years old boy?
Right. So it's good that this child has come for a vaccine certificate and a fitness certificate for tracking. And this is a good opportunity to make sure that you do the catch-up vaccination. So all government NIP vaccinations have been done. So the vaccines which are not done, it seems, are typhoid, hepatitis A, chickenpox. So at least this much as a catch-up vaccination. MMR, they may not have received, they have received MR only. So you can take an opportunity to give MMR also as 2 doses. So chickenpox 2 doses, 4 weeks apart. MMR 2 doses, 4 weeks apart. Hepatitis A, if you are giving inactivated vaccine, then 2 doses, live vaccine, then single dose, and a typhoid single dose. This much as a catch-up vaccination. Hepatitis B, I'm sure they have received in government, so not required. So it's done. Then, because this child is going for tracking, we also need to look at a special situation. So depending on that, like it is recommended that at least maybe even a pre-exposure rabies prophylaxis one can consider. If the travel area is such where it's a JE belt, then maybe that also. A flu vaccine as a routine vaccine given at many times, but may not be required, may be required depending on how you take it. So that is one thing. Meningococcal vaccine not routinely recommended for travel, at least to tracking. But of course, if the person is going for further studies to US or for Hajj or for such area belt where there's going to be overcrowding or specific reason, then we may consider. PCV is already done as a part of NIP. So flu, okay, plus minus. JE, depending on the belt where he's traveling and how much he's going to stay there. And rabies vaccine, pre-exposure prophylaxis, not the post-exposure, but a pre-exposure. This dose that you mentioned here is a post-exposure dose. So these are 2 things which we should consider when this child is going for tracking. And we must make sure that all this is done significant enough time, at least 2 weeks before the child is leaving, especially for JE and other things. But then it all depends on how much time the child has and how late he has come to you, so how much time you have. So even if you're not able to do everything or you're not able to schedule everything at that point of time, you need to do it even after he comes back from his like tracking trip. So you must explain to him the importance of all these vaccines. Fine.
Ramesh bhai, I want to ask, at this age of 13 years, this boy, which are the primary vaccination which are advised by IAP ACVIP for this age? Sir has mentioned catch-up vaccination and special situation vaccination, but which are the primary vaccines which are required at this age?
At this age, required vaccines are Tdap vaccines and HPV vaccines. Both are in schedule after 10 years of age. And TD at the age of between 16 to 18 years age.
I am a simple pediatrician with so many brands available for DPT, like Bustrix, which is Tdap, Adacel, and Tetraxim also available. So at this, which vaccine use, when to use which vaccines? I am very much confused. Sometimes 7 years old boy came, sometimes 5 years old came. Which vaccine should be given to when?
Up to less than 7 years age, we can use Tetraxim wholesale DTP vaccines, and above 7 years and above, we can use Tdap as a catch-up vaccine, as well as in routine vaccine between 10 to 16, 10 above the age of 10 years. We can use Tdap vaccines. So low diphtheria and pertussis dose in about 10 years, and as a routine, and for catch-up above 7 years. And below 7 years, we use wholesale DTP vaccine, a cellular as well as wholesale vaccine.
So Divyan bhai, I agree with Dr. Unmesh bhai that under 7 years of age, we use capital D, capital T, and capital P either WP or AP, whatever. Because of the fear of reactogenicity above 7 years of age, we would use a Tdap vaccine as catch-up also, or as primary series, depending on if somebody has not taken any vaccines, then you need to do vaccination accordingly.
Dr. Tushar sir, if the patient has got this vaccine and after DPT vaccination, up to how much time TT immunoglobulin or TT for the injury or wound is not required, sir?
So if somebody has taken primary vaccines, then so anytime in life, so you need to understand that for every injury you don't need to give TT. Somebody who has received primary vaccination up to 5 years for a clean wound, you don't need to do anything, and for an unclean wound you may give TT. Beyond up to 10 years, for even for a clean wound you may not do anything. Beyond 10 years you will give one TT. And somebody who has not received any vaccine and there is an unclean wound, then and then there is a role of TT immunoglobulin.
So I ask our surgeon friends that don't give every time TT vaccines. Whenever the patient came,
It can
they
cause
usually
arthus reaction, serum sickness like reaction, and therefore TT repeated doses is not indicated, especially in every injury that you get.
That's my question towards our experts. Sir, Tushar sir has mentioned capital D, capital P, capital T up to this much of age. If someone has done a mistake, then what can be happen, or what should be the sequence after this wrongly given DPT or something, or not wrongly, but not wrongly selection of brands?
Yeah, of course. Yes. Before that, talking about the immunoglobulins, that we need to know three things. One is the whether he has received 3 vaccines of tetanus toxoid before or less than that. That's the first thing. Number of dosage of tetanus vaccine he has received previously. Second is the duration of the last vaccine dose, whether it was below 5 years or between 5 to 10 years or more than 10 years has been lapsed during the last vaccine time frame. And the third is the type of wound. And depending upon all these 3 factors, we need to decide whether immunoglobulins are required for this wound management or not. That's the story about it. Now, coming to the vaccine that you said, that suppose somebody has given the capital D, capital T, capital P vaccines, which are the full dose vaccines beyond 7 years of age, that means it's a mistake. It's an inadvertently they have given it. Now, what is going to happen is they're going to be more reactogenic. And because they are going to be more reactogenic, it is going to be a bit of a problem. But having said that, if they have given it inadvertently, we still need to count it, because despite that reactogenicity, the dose that has been given will definitely help that child to take care against those diseases. But if at all somebody has given a Tdap vaccine as a booster of 5 years or a booster at 1.5 years, they still are counted, though the dose is suboptimal. But if they have given this Tdap vaccines as a primary dose, like first, second, and third, then they are not to be considered. You have to revaccinate these kids. You cannot give these small Tdap vaccines as a primary dose vaccination. But if they have given it as a booster dosage, a first booster or second booster, though it's a wrong method of doing it, still they are counted. And if the full dose given after 7 years, it is going to be reactogenic, but they will be counted.
Right. Very well explained, sir. Sir, Kasi sir, any comments on this?
No, I think Ganesh has explained it very well. I have nothing to add.
Yes,
Thank
sir.
you.
So, friends, no Tdap for a primary immunization. One message: Tdap after 7 years, that is a better, and no capital D, capital P, capital T after an age of 7 years. This we got a message from for the DPT vaccine, as well as this is a schedule which is nicely explained by Dr. Tushar sir for adolescent immunization program. So another opportunity during the orientation class of first year MBBS students, almost half of the students are unaware of their status regarding vaccination with DPT, MMR, varicella, hepatitis, HPV, everything. Should they, Dr. Ketan sir, should they receive all the vaccines for which there are no records? Like in clinical scenario, we have this type of patients also. But this, you are a HOD of pediatrics of this medical college, and students came to you directly. Should you, what will be your approach? Are you going to give everything for which records is not available?
Yeah, because you are taking the base of Purple Book. It is written there that when there are no documentation, you have to give all as ketchup, except for influenza and polysaccharide pneumococcal 23. But then, as a practical point, if there is a very sure history somewhere written in their old papers, they can bring their old notes if possible. There they may find a history of varicella written by somebody, then you can very well avoid it. Similarly, if he had suffered from hepatitis A, you may avoid it. Similarly, measles history, if there is there, you can avoid that thing, mumps also, and rubella. But then, most of the time you won't get it. So, again, because these are MBBS students, it will be easier to convince them for the vaccines. And antibody titers, again, I would definitely recommend that because he is a medical student, he is under you, and you can spend some money to get the antibody titers which are available. Say MMR titers are available, varicella titers can be there, hepatitis B titers can be there, hepatitis A titers can be there. So all those things, if done, though it will be a costly affair, but then they can avoid those vaccines if they emphasize on it. Otherwise, vaccines, if they are repeated here, except for DPT, most of them, they won't have any major side effect, or even they are very well tolerated. So they should be given. And I don't think why I don't know why Purple Book has mentioned except for polysaccharide, pneumococcal 23 and influenza vaccine. This statement, I would like to get some light on it from the experts also.
Yes, sir. Dr. Kasi, sir, for the same question by Ketan, sir.
Now, I think here we have two options, as was pointed out. One is either just make a policy that all students should receive all the vaccines, or the second is discuss about the choice of doing the antibody titers, the cost involved, the delay in giving the vaccination. And if titers are negative, they bear the cost of the test plus the cost of the vaccine. So discuss and let this be an individualized decision, because see, the concept of autonomy, the vaccinee should have the right to take the decision. So these choices have to be put forth in them, and then you take a particular decision. Now, this exclusion of influenza and the polysaccharide vaccine is not basically IAP, it is from the CDC recommendation. And the reason given that is influenza vaccines are generally given in mass campaigns in USA every year. So records are usually not available. The second is the polysaccharide vaccine is given only to certain select population and not everyone. So there's a very less chance that someone may have missed the polysaccharide vaccine, especially a normal healthy individual. These are the two reasons why for these two vaccines, they don't insist on having records. I think that is the reason for these recommendations.
I think then we should remove the influenza part from it.
I think this scenario holds,
because the base has been US where mass vaccination is going on, and in India we don't have that mass vaccination.
We don't have it. That's right.
We should remove it.
Yeah, worth considering it, definitely.
But I think, sir, this scenario holds true for each and every population, because see, most of those kids who are 20 years or 19 years old, either they are not aware of which vaccines were given, neither the parents are aware, and not the records are there. So then it becomes like revaccination for each and every cohort. That's going to be really difficult.
but less expensive than doing the antibody titers, more cost effective. And when you repeat a dose, except for DPT, if you repeat doses are not harmful in any way.
But it's going to increase the cost. No, the burden of cost, the burden is going to be very high for the society itself.
How are you going to be sure they are protected then?
But then we can have a bottom line that because these are the medical students, they are into healthcare professional, they have a risk of exposure is very high. For them, probably we might reconsider.
Yeah, definitely. That is right.
Not for
try to get try to dig out the records first. Don't over enthusiasm for the grabbing the opportunities, as we have made a slide of grab the opportunity. It's not just that every time we consider this is an opportunity.
And is there any chance that we may exclude few vaccines like pneumococcal? Don't need in this age, so exclude it.
Yes, sir.
Agreed.
Yes, sir. Agree, sir.
We can minimize the number of doses.
Okay, let's move on. Another case one. I request expert also. My panelist also said there are multiple questions in one slide. So please give answer of the question which is asked to you, because if you give an answer of next question, you will grab the opportunity of your next speaker. So thank you very much, sir. Mother of 12-year-old twin child. He came with some information and many questions in your OPD. Unmesh bhai, the first question to you: does the vaccine of cervical cancer needed for my daughter, and why? Please be brief for answers. I request all the panelists, please be brief for the answer. Unmesh bhai, does the vaccine of cervical cancer needed for my daughter, and why?
Yes, HPV vaccine is must required for your daughter. And why? Because cervical cancer is fourth most common cancer globally, as well as second most common cancer in India. And the morbidity and mortality is very high as per 2024 data of ICMR. Approximately 80,000 cases as well as 40,000 mortality in India as per 2024. And it is recommended by vaccine is recommended by IAP as well as WHO, and currently given in 160 countries all over world. That's my answer.
Unmesh bhai, being a pediatrician, every one of us know this. This is a quite crystal clear question. We want our science also, but we want to learn your skill, how to counsel. So please, every one of panelists, please make a sentence which you use to counsel the patient, because we want to learn the counseling skill from you also. That that why I need for my daughter, and why that you make a clear that it's a very crucial vaccine. Now, next question to Tushar bhai. How will you counsel? My child is just 12 years old. She have not started periods yet, and she is not sexually active also. Then why a vaccination against sexually transmitted disease to my child?
Right.
Please counsel.
So I would not promote this as a sexually transmitted disease vaccine. One. Second, this is not a vaccine only for cervical cancer, though it is one of the important indication. So we should promote it as a HPV vaccine. So like as we do it for measles vaccine, mumps vaccine, chickenpox vaccine. So all viruses, when we say, we similarly promote this vaccine as a human papilloma virus vaccine. And there we try and make them understand that beyond cervical cancer, it is also going to be helpful for vulval vaginal cancer, anal, anorectal, oral, oropharyngeal cancer, not only for females, but for males. Since we are talking about our patient here, we need to make them understand that it is a very important vaccine for so many cancers. Other thing, why at this age when she is not sexually active, not menstruating? Because we need to make them understand that if we give early, the immune response is very good. The effect of the vaccine is very good. It is long-lasting effect. and the number of doses required would be less, the cost of vaccination would go down, and it has ample of advantages. So with that all, it is very easy to convince them that the right time to vaccinate is now. If we do it after 14 complete years, we'll end up giving more doses with more cost, and the effect is best if we give as early as possible. Yeah.
Thank you very much, sir. Ketan, sir. I heard on WhatsApp that it affects the fertility and increase the chances of PMOS or PCOD. Is it true?
Yes, because you are demanding a statement of counseling. The first thing we should tell the parents that, yes, I agree with you that if there is such a propaganda on WhatsApp, it will be fearsome. Second thing would be that whom should you believe? The real makers, most of them, they are non-doctors, they are anti-vaxxers, they may do it purposefully, and they are also politically motivated. So these three things makes the WhatsApp university. And lastly, we should tell them what is the scientific data. The most dependable scientific platform for data is Cochrane based. If the parents they are educated, they can very well be convinced that Cochrane is their scientific platform. And a very big population-based studies have revealed that there is no effect on ovaries whatsoever. So PCOS or PMS is out of question. And regarding fertility is the other way around. Because there won't be any precancerous conditions which affects the cervix and does the fertility. Fertility is better. Even now, newer data is coming up that the HPV-induced semen quality deterioration also can be prevented with this vaccine. So boys also should be given. So this is what we should explain to the parents, and then tell them that whatever doubts you have, you can still discuss with us, take your own time, and then you can give the vaccine.
Ganesh, sir, I want to ask you this in a counter question in this era. Because from where this fertility and PMOS has started, is there any study? Because whenever I have taken a lecture in IMA also, one or two gynecologists, they just argue for this PMOS. One gynecologist has told me I am not going to give a Gardasil 9 or for because it affects fertility. Okay. Is there any small or any study there? Why this came in the picture, particularly fertility and this PMOS?
No such clinical studies that support this myth. Basically, this has come out with the anti-vax mentality, and they wanted to score something. That's the reason why it has been created. There's no significant clinical study that has shown that it affects fertility in any way. That's the first thing. I doubt if Kasi sir probably may know about this, but there's no such evidence study that has supported that the fertility is at stake.
Yeah, now regarding fertility, there was a paper published which described a case of primary ovarian failure temporally associated with HPV vaccination. And that's where all this entire story began. Subsequently, we must remember that over 700 to 800 million doses of HPV vaccine has been used so far. There's a very strong surveillance system, PMS, going on for this vaccine till this day. And in 2024, the Global Association of Vaccine Safety published safety data of HPV vaccine. And they have said that there is no credible evidence that HPV vaccine is associated with any of the side effects, like either venous thromboembolism, primary ovarian failure, chronic regional pain syndrome, and many of the autoimmune diseases, etc. We must remember that when an adverse effect occurs with a vaccine, all of them are temporally related, but they may not be causally related. Here, the association was temporal, but not causal. So now we have definite data from large PMS studies showing that there is no link between HPV vaccination and either primary ovarian failure or because of PMOS as it is now called.
Okay, so PMOS and fertility out of question. We have enough evidence how to counsel. Yagnesh sir. Sir, there is 2 and 3 doses of HPV vaccine is written on your case file, and government is advising only 1 dose. Is the vaccine offered by government is more potent, or why you are advising 2 or 3 doses written on your case file? Yagnesh sir, please answer.
Divya, I think you were waiting for one of the most controversial question to be asked to me.
Yes, sir. I will take everyone's opinion here.
Number one, the file can be printed a long back, so number of doses might have changed later on, so that is not the issue. Now, what we advise, whether we advise right now 2 doses or 3 doses or 1 doses, that is what is important is. At this juncture, one thing one must remember, the purpose behind vaccination. The purpose of vaccination for a government is to cover as many individuals as possible with a lesser cost and with minimum number of doses. While the purpose of an individual, a doctor, private doctor, is different, is to cover that particular individual with maximum efficacy, maximum possible. For example, if we forget right now HPV, we just look at the other vaccines like rotavirus vaccine. Government is giving at the above age because they have a different purpose. While for an individual, we want to avoid intussusception, so we do not cross that age limit. So similarly, for HPV, single dose vaccine studies have been there. Recently, there have been papers, there have been studies, especially from Malawi, which has said that the single dose is sufficient enough to give a reasonable protection to the individuals, at least as of now. So that is what is been accepted by even WHO, and that is why government is giving a single dose to cover more number of individuals. Suppose government gives in 2 doses, immediately cost will be doubled, immediately. And the advantage of giving that particular advantage of covering more children will be more beneficial than the minor difference in the efficacy. So government will definitely go for the single dose. Now the question is whether in a private setup we are supposed to go for the single dose or the double dose. Recently, there has been a change in the ACVIP recommendation, our parent body with regards to the immunization. It states that the single dose may be given up to the for girls only up to 15 years of age. So 3 things: for girls only up to 15 years of age and may be given. So there is no clear-cut, strong recommendation as far as a private practitioner is concerned. So a simple private practitioner like me will definitely wait for a more robust data, more recommendation from experts like Dr. Kashi and Dr. Ganesh, and strong recommendation from the IAP. So as long as that recommendation is not come, probably I'm going to stick with the 2 doses for the below 15 years and above 15 years, 3 doses.
Okay, sir.
Even one more thing. Recently, in one of the IMA meeting, I have heard that the government is also going to give a 2 dose, but straight away they have not said it is 2 dose. At present, they started with 1 dose, and after 3 to 4 months, they are going to declare the second dose after 6 months. So we will definitely wait for a private practice.
Dr. Unmesh sir, you are in ACVIP member. So this is somewhat. I will come to Ganesh sir and Kasi sir. This is a burning question, so we will give a full time to this. And I beg a time from Samir sir for this question also. So Unmesh sir, Yagnesh sir is telling that this 2 doses scenario and 3 doses should be continued. Any comment on this statement, or would you like to agree or disagree, or want to add something from ACVIP side?
As per available many recent studies, recently, NIH studies published in December 2025, which conclude that HPV vaccine effectiveness against 16 and 18 serotype for 5 years with effectiveness more than 95%. This is a recent study published in December 2025. And other study also in Kenya and Tanzania, which shows persistent vaccine efficacy for more than 95%, mostly 5 years period against HPV 16 and 18 infection. So, and also Costa Rica study also shows 10 years persistent antibody titer for 10 years, as well as our Indian study also shows persistent protection, persistent vaccine efficacy for more than 10 years against HPV 16 and 18 infection. These are the major study which prove that one dose may be protective for more than 10 years.
Sir,
And
simple question.
Unmesh sir, just one side question to you. What are the number of doses you are recommending right now in your private practice? 1 or 2?
I started 1 dose. I
Okay, you
started
had already
1
started.
dose.
Okay.
Okay.
Sir,
Ganesh sir, a
yes,
simple
before we go further,
Ganesh sir.
one question to before Kashi sir answers, one question to Kashi sir only.
Concludes this talk, this question. What the fact is basically 2025 guidelines, ACVIP guidelines changed according to the WHO recommendation. WHO has been saying that single dose is going to be a game changer, and it recommended it to use it into your UIP. And according to that, only ACVIP has taken that stand that single dose is good enough. Now, why that single dose is good enough? As Unmesh Bhai was saying that, no, there are quite few studies which have shown that, like the oldest study, the more than 10 years follow-up study is basically that Costa Rica study, which showed that comparable efficacy from 1 to 3 doses of Cervarix when it was compared for HPV 16 and 18, even after 10 years. And then the Indian IRC study in 2009, then the Doris study in 2017 from Tanzania, the Kenshi study from Kenya in 2018. All of them have shown that the single dose has almost an efficacy of effectiveness of almost more than 98% as compared to 2-dose. So that's the reason why, when it is showing such a wonderful effectiveness, why we need to have 2 dosages. And that's the reason why this change has come. Now, there are some fallacies to it because these studies have been done only on girls, not on boys. That's one thing. The long-term follow-up is almost the 10 years follow-up with the Costa Rica study, but that was done on a Cervarix only for 16 and 18 serotypes, not other serotypes. Those are things. Now, the booster recommendation probably is needed or not needed. Long-term follow-up would be really necessary in this scenario. But as of now, 1 dose is sufficient enough, and we need to stick to that.
Okay.
Over to Kasi sir.
Kasi sir, I want to ask,
okay.
actually we have a somewhat lacking in time also. So 2 specific questions, sir. One is, every study shows a 10 years good potent immunity in 10 years study. Can we rely on this study when we are asking for a vaccine which have to give a protection at the age of 45 years of HPV cancer, cervical cancer age, which is more than 40, 45. At the age of 12, we are giving vaccine and we have a study data of 10 years. Another things, ACVIP recommending at 9 to 15 years single dose, and companies are telling 2 doses. If we follow the ACVIP and any medical legal issue or should be there, how to proceed? So two things, longitudinal study duration.
Sir, one more question associated with this.
legal.
One more question associated with this before you answer. That the studies were on Cervarix and Gardasil, but none of them were on Cervavac. So if we are changing the brand, is there any issue with that. Yeah.
Kasi sir.
Okay, fine. I think I'll require a little more than 2 minutes, please. Okay. Now,
No problem, sir.
Ganesh has said very well that the Costa Rican vaccine trial showed that there was no difference in efficacy against persistent infection of 1 doses versus 2 and 3 doses. Similar data came out from the IARC trial from India. But both these trials, Costa Rica was a post hoc analysis. IARC was not a randomized control. Randomized control, because it was stopped, it was converted into observational long-term cohort study. This is not very high-level evidence. Based on this, numerous randomized control studies have come. To name a few, the Kenshe, the Doris, the Escuda, the Hands trial, at least about more than half a dozen studies. All of them have uniformly shown that taking the end point as 6 months persistent infection, whether you give 1 dose or more than 1 dose, there is no difference in efficacy. Follow up till 60 months, not longer than that. But if you look at the antibody titers are definitely lower with 1 dose compared to 2 and 3 doses. But still, even at 60 months follow-up, the antibody titers with 1 dose is far, far higher than that following a natural infection. Okay. Now, if you look at the curve of the antibody titers, okay, it initially rises, falls, and then it has plateaued till 60 months. That is, there is no fall in titers after 12 months post-vaccination. So this gives a lot of hope that this is going to last for a very long, long time. The third point is, what is the relationship between antibody titers and protection? Now, in the Future 2 study, which was done with Gardasil 4, 32% of the cohort, vaccinated cohort, became seronegative against type 18. 32%, almost 1/3. But still, over 14 years of follow-up, there was no reduction in efficacy at all, indicating that demonstration of persistence of antibodies does not mean that it is essential for protection. And why is this so? If you look at the pathophysiology, you require very few HPV organisms. They say 10 to 12 viruses are enough to initiate infection. The second thing is the amount of antibodies that you require at the cervicovaginal junction is in picograms, very, very low. And the present methodologies that we have for testing antibodies in the serum does not measure these very low levels. So taking all these into consideration, we must say that there is robust data that 1 dose is sufficient for long-term protection. There are certain gaps. One is they've taken the endpoint as persistent infection, not CIN 1, 2, and 3. Yeah, CIN 2 and 3 are more specific. Persistent infection is not so specific. But we must remember that the first stage for even CIN 1, 2 is persistent infection. So that is also not there. Second, what about the immunocompromised? What about males? Do we have data about that? No. And the third thing is, of course, is 6 years follow-up sufficient for saying long-term protection? And as I told you, looking at the antibody titers, I think it is sufficient for long-term protection. I mean, I honestly feel that 1 dose is really enough, especially between 9 to 15 years of age, maybe even up to 20. But beyond 15 years, I think we should go for the 2 doses. But as far as 9 to 14 years, the data is sufficient for recommending a single dose.
Thank you, sir. So that's very clear. IAP ACVIP recommends for 9 to 15 years a single dose. Beyond 15 years and immunocompromised, 3 doses policy is continued. There is no recommendation of single dose after 15 years. And for boys also, 2 doses schedule is recommended. So here we stop this burning question.
One last question, I think, Dr. Divyang.
Yes, sir.
I think, Doctor, this question regarding can we use it for all the brands? Now, the WHO has said that for vaccines which are licensed based on non-inferiority to another vaccine which has efficacy data, the one dose does not apply unless they demonstrate non-inferiority till at least 2 years of follow-up. So now Servavac has been licensed on basis of non-inferiority to Gardasil 4. Now they are doing a non-inferiority study. They have completed 1 year, the second year is on. So 1 year follow-up shows non-inferiority. We are waiting for the 2 years. By then, WHO pre-qualification also will occur, and then we can confidently give even 1 dose of Servavac. Although now technically there's no reason why you should not give 1 dose of Servavac. I mean, I am using even Servavac single dose also.
Okay, sir. Now, Dr. Ketan, sir, there is a question. Boys, we have considered very well. Okay, boys require cervical cancer vaccine because it's not a cervical cancer vaccine, it's HPV vaccine. But Ketan, sir, why so much variation in the rates? Some is 2,000, 4,000, 10,500, and which one is the best? According to rate, the highest rate is the best, or lowest is the best? Which one is the best? Ketan bhai.
Unmute yourself.
Yeah, thank you for pointing. I think the funda of the rates is based on what the company has invested in, what they want to recover. Very basic funda is there. So, say suppose the 4-valent vaccines versus 9-valent vaccines, the research investment and all, everything they try to recover. And again, the non-inferiority trials would be even cheaper than what has been for the actual basic research. So that is the basic funda behind it. Which one is best? Again, because they are licensed for use by standard authorities, they are all same and they have been proven scientifically with non-inferiority trials also. So there is nothing much to choose amongst them. But on personal basis, I would definitely choose the original researcher's product because biologics, they don't behave same everywhere. And that is my own choice because of the behavior of various biological products.
So, in short, all vaccines are potent. There is no non-inferiority in any brand, but it's a personal choice on the one-to-one basis. But any vaccine you choose, but please vaccinate. That is the main thing behind this. Ketan bhai, anything left? We have counseled very well to this mother. Anything left? Do you think that in this patient, something to grab the opportunity?
What is the age of the mother also we should ask?
Yes, exactly.
If we want to increase the umbrella, then yes, definitely.
Yes, definitely. We can counsel the mother also. Yagnesh sir, a 16-year, we will go fast also. A 16-year-old girl who is a daughter of doctor family came to you during the cluster outbreak of fever and CNS infection in the hostel and outside the hostel, Engineering College, Gorakhpur. Now they want a guidance regarding vaccination for preventing aspect. Vaccines for preventing aspect in this scenario.
Gorakhpur is an endemic area for JE. So probably the outbreak which is going on with fever and CNS infection may be a JE infection. We do not know right now. But because the child is studying in the JE endemic area, the individuals should be protected against the JE. This is the one basic question, whether there is an outbreak or no outbreak, the child should be vaccinated against JE. So give a vaccine, JE vaccine, 2 doses schedule, 1 month apart, 4 weeks. And minimum, of course, age is 1, so we had already crossed that area. So we can give it in any individual.
Yagnesh bhai, can we also consider giving a meningococcal vaccine since she's in the hostel and adolescent girl?
This is the second area where we should be doing it because the meningitis, this could be a meningococcal meningitis. Exactly. Of course, the meningococcal meningitis will behave differently and will have a different attention from the local authorities also. But we should definitely consider when the child is studying in a hostel, the environment is beyond our control. So we can definitely consider giving a Minectra or the other Minivio, whatever vaccine.
Pinpoint and to the point question to Dr. Ganesh sir. Recommendation of IAP we all know. Individuals living in endemic district. Day to day we are not following which districts are endemic. The simple question, should I give JE vaccine to my both the kids? Because I don't know when the vaccination has been started, it start with a 3 district. Now it's 300 plus district. Should I give vaccination to my kids? Every pediatrician's question. JE vaccine.
That's always a debatable question, which we often come across during every conference and every discussion. See, having vaccines and giving vaccines to whomsoever they have demanded, it's a good policy, but that actually is not the exact scientific basis of giving vaccines to each and every one. No, we need to understand that this particular vaccine is only for those kids who are into the endemic zone. Now, if you want to give it to your kids, well and good, but you need to qualify certain aspects to it. Now, what those aspects basically is, if your environment is ecologically as conducive as the endemic area is, if you have those animal reservoirs which are there seen in the endemic zone, if your area is very proximal or very close by to the endemic districts around you, or there are vectors also, the transmitting vectors also seen into your area, probably these are the things. If you see, I think there is a logic in giving this vaccine to your kid. Otherwise, no, it will be just a well-wishing, but no scientific basis to give this vaccine to each and everyone who comes across.
Okay, thank you, sir. When I read about this vaccine, Japanese encephalitis vaccine should not be used as an outbreak response vaccine.
Yeah.
2 quality inactive vaccines are available, and the academy urges the government to introduce one of this product in universal immunization program of affected district on cost-effective analysis. Any light on this statements, Kasi sir?
Now, JE vaccine, as you all know, is recommended only in declared JE endemic areas. The WHO in its position paper has very clearly stated that in districts which have a common border with JE endemic districts, and if those districts have environmental conditions conducive for transmission of Japanese encephalitis, like you have the mosquito, you have the pigs and wading birds, you have open water bodies, one can consider giving Japanese encephalitis vaccines to all the children and not wait for it to be declared as an endemic area. So we cannot make a blanket ban. Now, I will give you a simple example. Bangalore is surrounded on 3 sites with JE endemic districts. But in the past 30 to 35 years, whatever JE has been treated in Bangalore hospitals, we did a study on this. None of them were local Bangalore. They were all from surrounding districts. So in spite of conducive environmental conditions, it does not mean transmission is occurring. So in Bangalore, there is no recommendation, at least many of us, we don't use the JE vaccine. So I think it's something individual. What is the risk perception by the individual pediatrician, which should decide rather than any blanket recommendation for JE vaccine for use in all the districts. It's a safe vaccine, it's a very effective vaccine, but it should be used only where it is necessary.
Okay, thank you very much, sir. We will go little
Running
fast.
beyond the timeline.
Yes,
So,
yes, sir, yes, sir, yes, sir.
Yeah,
Yes, sir. Ketan sir, a very clear-cut case, known case of thalassemia major, stem cell transplant has been done 1 year back. Now a tapering of this transfusion independent, immunosuppressive has tapered off. When will you initiate the vaccination? What will be your first preference? And what is the schedule to be followed? Ketan sir.
Yeah. So when will you start? I think it has been enough time after the transplant and also tapering of the immunosuppressants. we can start it right away.
Okay, thank you very much.
Yeah. And the schedule would be again the preference that earliest we can give is PCV. Earliest we can give to these children, and then followed by the polysaccharide 23 if there are no evidences of graft versus host reaction. Next immediate you can give is influenza vaccine, inactivated one, 2 doses, and then if the child is less than 9 years, then 2 doses. Then if it is more than 2 years, then single dose, then repeat annually. Other things we can give DPT, HIB, IPV, hepatitis B, beyond 6 months of the transplant, which has already been, which is already there, and the routine doses, the routine primary schedule can be given, because this patients has undergone the ablation, bone marrow ablation, so they have lost almost all the memory cells. So they need to be given primary doses also. And the live vaccine should be given after 2 years, say MMR and varicella.
So we can start immediately. PCV will be the first choice, and followed by influenza and other vaccines. So if it's all are okay, then we will move on second case. That is
Just
a simple
one comment.
case.
Just one comment.
Yes, sir. Yes, sir. Yes,
The
sir.
first vaccine should be influenza. Influenza is recommended anytime, even within 3 months, especially if you're approaching a influenza season. So inactivated influenza, all inactivated vaccines can be started 6 months later, 6 to 12 months later, and live vaccines are given after 24 months, provided there is no graft versus host disease. And remember, because there's marrow ablation, you are going to restart the entire schedule and not just continue or give boosters. It is reinitiation of all schedules.
Yagnesh, sir, 18 years old girl in medical college hostel come to you as a 2 of her hostel mates develop chickenpox 3 days ago. At present, she is absolutely normal and unsure of her vaccination status or past history of chickenpox. Raj, how will you manage this situation? Would you give a chickenpox vaccine immediately? And how effective post-exposure varicella vaccination? Yagnesh, sir.
Yeah, number one, the chickenpox has a longer incubation period in the range of 14 to 20 days. So if vaccination is given within a certain period of time, window period, definitely we can abort the or we can alter this next situation. So if preferably within 3 days, if the vaccine is given, it will abort almost 90% of the cases. Up to 5 days, it will abort even good, but beyond 5 days, probably it will not be that effective. The child has already crossed 3 days, or about to cross 3 days, so one should definitely vaccinate against the chickenpox vaccine if there is no documented evidence of vaccination or a disease in that particular child. So this is regard to the first. Second question was immediately vaccination effective, we had already gone. And the last question, if we choose to vaccination,
Yes.
then they come out with the proof. The extra dose will definitely no harm. So don't worry about the extra dose. You give the vaccine. Yeah.
Yes, sir. So clear-cut message. In any case of chickenpox exposure, though more than that is a definition of exposure, then give a vaccination, even if they come after a 5 days, because it will help to provide the protection against the future. And for catch-up vaccination, we all know up to age 13 years, 2 doses 3 months apart, and after 13 days, 2 doses 4 to 8 weeks apart. Very briefly to Tushar sir.
Divyansh, just interrupting, the meeting will end within 3 minutes, so just wind up.
Okay, sir.
I'll say, Divyan, I have questions next time.
Okay, no problem, sir. Only one question to all the dignitaries of adolescents. This question. 14 years old adolescent girl brought to HPV vaccine. Mother diagnosed CA cervix metastasis 2 weeks ago. Parents unaware about HPV vaccine. Now become first time. A child is frustrated, refused, and on a very next day, father came with two healthy uncles and tell you, doctor, we will restrain her. Please administer vaccine. The girl is terrified and start weeping and shouting. Will you forcibly administer the vaccine to 14 years old adolescent? Samir bhai.
For anybody, forcible vaccination is not a good idea. You must counsel properly, take the child into confidence. Adolescent understands everything, and you have to put a lot of effort to make sure that you are able to counsel and take the confidence of the child. Because for a 50 kg child to restrain and give is not a good idea.
Samir sir, anything
No.
from adolescent side?
And forcing an adolescent will almost have a negative effect.
Yes.
No, basically, counseling is the most effective way to communicate one important thing. Force is never done because there is always some immunity will be there, and we are now giving that for the more protection. But if it will leading to the more problem to the child with the syncopal attacks and other things, we have to prevent that. But of course, we have to vaccine. Immunization is the most important and priority base as early as possible.
Thank you very much, sir.
In this case, there is no hurry. Should be the first thing told to the relatives.
Thank you very
Because
much,
that
sir.
is the
Thank you.
precipitating thing. Yeah.
I will just
you very
add a
much.
little on this last question, please.
Yes, sir.
See,
Yes, sir.
the prime principle, the first principle of medical ethics is autonomy. The patient can decide whether he wants to take the treatment or no. Here, legally, the father can take the decision for the child in our country. So legally, you're right. You can force and give. But ethically, you're wrong because apart from consent, there's a question of assent by the adolescent. Assent. The adolescent has to agree for the procedure. And is the adolescent ready? There are certain parameters, something called the Gillick criteria, whereby you can ascertain whether that particular adolescent is fit enough or mentally, mature enough to take these decisions. Something called the mature minor concept, which is generally above the age of 12 to 13 years. It is not legally valid in our country, but legally valid in many of the Western countries. On the other hand, suppose this was not HPV, but this was category 3 exposure rabies, then what would you have done? You see, that is where it's a question of life and death. So you can give by force, but in this case, it is not urgent. There is no harm in, postpone it by maybe 2 weeks or 3 weeks, repeated counseling. In fact, this case I put up, it had happened to me, and believe me, it took me almost about 2 to 3 weeks for me to convince the girl to take the vaccine. Ultimately, she took it. So patience is necessary. Assent is ethical, but not legally necessary. And I think ethics have to be followed. Thank you.
Thank you very much, all the panelists as well as experts, for such a wonderful and lucid discussion. I hope we point to your queries, audience also. And now I hand over to Bhavi for next proceedings.
Yes, sir.
And
Thank you
sorry
yeah.
for taking more time.
One thing I want to give message. Pediatricians are very lazy
Unmesh,
about
only 1 minute is remaining.
vaccine awareness through WhatsApp status and YouTube video is very effective that I experience. So they remind their catch-up vaccine. Parents remind their catch-up vaccination if we remind through WhatsApp status or YouTube video.
Thank you, everyone, and for the excellent moderation, Divyang sir, and extremely satisfactory answers and discussions from the panelists and experts. We are really grateful. And moving forward, I would like to call upon Dr. Bhupendra Kapadia sir for the vote of thanks.
So thank you so much, all the panelists, expert guests, moderator. Thank you so much, all the delegates for attending today's webinar. And I request all those who are still not the members of Gujarat Adolescent Health Academy, Central Adolescent Health Academy, please be a member at the earliest, and we will see you again after 1 month with new topic. Thank you all.
Thank